Welcome to Chapter 19, Respiratory Emergencies. So, we're going to look at a little bit of anatomy and physiology again. So, we have that negative pressure system and positive pressure system. That negative system moves air in, and that positive pressure is used to move air out. And it's generated by the contraction and relaxation of all the respiratory system muscles. In our respiratory and anatomy and physiology, so inspiration, we have that active process. Use the intercostal muscles in the diaphragm to contract. The diaphragm lowers, the ribs move upward and outward, and air is pulled into the lungs. All of the other stuff on expiration is opposite. Okay, so it's a passive process, and then everything relaxes, the cavity decreases, and air is moved out. So adequate breathing, this is breathing sufficient to support life. Signs are generally a normal mental status and moving air when breathing. They have the ability to speak without having to catch their breath, and they also have normal color. They're pink, warm, and dry, with oxygen saturation in the normal range. So rate, rhythm, and quality for breathing, 12 to 20 for adults, 18 to 30 for a kid, and 30 to 60 for an infant. It's usually regular in rhythm, and breath sounds are present and equal without any kind of adventitious sounds like wheezing or crowing or anything like that. Inadequate breathing, so this is breathing not sufficient to support life. Signs include rate out of normal range, too fast, too slow, irregular, the inability to speak. They may have a silent chest, low O2 sat, agonal respirations, irregular rhythm, diminished or absent lung sounds, and then a poor tidal volume. On an infant, just remember that they're smaller. They can become more easily obstructed. They have bigger tongues in their mouths compared to adults. They have a smaller, softer, more flexible trachea. And all of that cricoid cartilage is less developed. For infants and kids, inadequate breathing includes nasal flaring, grunting, and a seesaw breathing motion where their stomach deflates when they take a breath in, and then it inflates when they take a breath out. So we can give, for inadequate breathing, we're going to assist with supplemental oxygen. We can do that with a pocket face mask, a 2 rescuer BVM with supplemental oxygen, or a 1 rescuer BVM with supplemental oxygen. Chest rise and fall should be visible with each breath, and we're going to ventilate at a rate of 10 to 12 for adults and 12 to 20 for kids and infants. Increasing pulse rates can indicate an inadequate artificial ventilation in adults, and decreasing pulse rates indicates that you're not ventilating adequately for kids. So the breathing difficulty, okay, this is a patient subjective perception. This is when they tell you, I can't breathe, or I'm having a hard time breathing, or something like that. Okay, they have a feeling of labored or difficulty breathing. The amount of distress may not reflect the actual severity of the condition. Especially with COVID, because of the fact that the way it works, they have low SpO2s, sometimes in the 70s and 60s, and they are sitting there talking to you absolutely fine, but they're actually hypoxic. Um, so it's just one of those things. Just assess your patient, not just observation, but you have to do other things as well. So OPQRST can be used when you want to kind of get a history of the present illness for your patient. So you're going to go through basically ask these questions or some slight variation of these questions. All right. So onset, provocation, quality, radiation, severity, and time. So you're going to look at all of these things and kind of get a feel or an assessment of what your patient is currently doing and how you're going to do it. So when we observe our patient, we're going to observe for um, altered mental status, any kind of unusual anatomy, such as a barrel chest, meaning that their chest kind of sticks out and it looks like a barrel. Their position, maybe they're in a tripod position, or they're sitting with their feet dangling, leaning forward. You're going to look at their work of breathing. Do they have any kind of retractions? Are they using accessory muscles? Do they have flared nostrils, pursed lips? How many words can they start say in a sentence without having to stop? Are they pale, cyanotic flushed? Do they have any kind of edema, either pedal or sacral, indicating maybe that they've got some CHF going on? What's their SpO2? Okay. Anything less than 94, 95 on that pulse ox, maybe having some difficulty breathing. Okay. This guy right here is in a tripod position. He's got a barrel chest. He's using some retractions in the chest muscles. He's having some difficulty. Note any kind of noisy breathing. So do they have audible wheezing, gurgling, snoring, stridor, coughing, any of that? We're going to listen on both sides, on both inspiration and exhalation, and then we're going to listen to the back as well for breathing sounds. Okay, so wheezes, these are high-pitched sounds created by moving air through narrowed passages. Crackles, these are fine crackling or bubbling, heard on inspiration, and is caused by fluid or by opening or closed alveoli. Ronchi, this is a lower pitch sound, typically resembling some kind of snoring or rattling, and it's caused by secretions in the larger airways. Stridor, a high pitched sound, usually indicating some type of obstruction in the trachea. So vital sign changes with patients who are having difficulty breathing. They can have an increased or decreased pulse rate. If they have an increased, that means that the body is compensating. If they have a decreased pulse rate, that means that the body is not compensating as well. They can have a change in rate and rhythm. They can have hypertension or hypotension as well. So patient care for a patient in difficulty breathing. So we're just going to ensure adequate ventilations. If their breathing is inadequate, we want to begin that artificial ventilation with the positive pressure. ventilation, the BVM or pocket mask or something like that. And then if it is adequate, do they either need a nasal cannula or a non-air breather? Place your patient in a position of comfort, administer a prescribed inhaler if they have one, and then administer CPAP or continuous positive airway pressure if they need it. We'll talk about CPAP here in a little bit. CPAP. So this is a form of non-invasive positive pressure ventilation. It has a mask and it basically blows in oxygen at a very high forceful rate, and it, I guess, low pressure. But basically what it does is that it opens the alveoli and it keeps them from collapsing. So when we normally breathe, we breathe in and then our alveoli kind of collapse in a normal lung. They kind of collapse. And then when we breathe out, on CPAP, if the patient is on CPAP or BiPAP, so what happens at night is, or when they have it on, they breathe in and there's pressure that still is coming in when they breathe out. So those alveoli are still being able to keep open, and it kind of also pushes, makes the surface of the alveoli bigger to allow more gas exchange to happen, and it kind of pushes that fluid out. We can use it in pulmonary edema, drowning patients, asthma and COPD, and respiratory failure in general. So pulmonary edema, flash pulmonary edema is the biggest reason that we use it, our CHFers, but in asthma and COPD, you kind of want to use caution for those, and start out kind of lower, because it's not their alveoli that's the problem. Their problem is bronchoconstriction. So you can use it, just be cautious. Contraindications for CPAP. So they have an altered mental status where they can't breathe in on their own, or they can't follow commands, because you do have to coach your patient in order to put this on. They may have the inability to sit up, hypotension or shock, because we're pushing in air. We're going to cause that hypotension to get worse, because the chest isn't normally in that positive pressure, or that positive pressure, because we're pushing in positive pressure and normally it's a negative pressure. So we're creating a whole different pressure changes in the chest, and it causes that hypotension. If they have any kind of nausea, vomiting, any kind of chest trauma, shock, upper GI bleeds, or any kind of condition that may prevent a good mask seal, like facial trauma or a beard. So again, side effects: hypotension. It can cause a pneumothorax, and it can also cause an increased risk of aspiration. So you're just going to explain the patient to the patient. When we use our disposable CPAPs, they typically come out of the package at like 10, or 5. I'm sorry, 5, and the therapeutic dose is 10. So you're going to start out at 10 and then lower it if you need to. You're going to reassess your patient, including mental status, vital signs, and dyspnea. And then this says to raise it. It only goes up to 10, the disposable ones. But if you need to lower it because your patient is not doing well, then you can lower it. Maybe compliance or something like that. It may be an issue. And then, of course, if the patient deteriorates, we're just going to remove that CPAP and begin ventilating. All right, so let's talk about some respiratory conditions. COPD, this is a broad classification of chronic lung diseases. It includes emphysema, chronic bronchitis, and some other stuff. Okay. Um, Overwhelming majority of these cases are caused by cigarette smoking. Chronic bronchitis, this is when the bronchial lining is inflamed. Excess mucus is produced, and those cells in the bronchioles that are normally clear, we get these mucus accumulations. So this is kind of a picture of the alveoli. You can see that in our chronic bronchitis patient, we get this mucus buildup that occurs in here. In the emphysema patient, these alveoli don't have the little walls in between each grape, and so because of that, then our surface area is decreased, and then that means we don't get as much gas exchange in there. So again, emphysema, the alveoli walls break down. We lose lung elasticity as well, and then this results in carbon dioxide being trapped in the lungs. Asthma, this is a chronic disease with episodic exacerbations. During an attack, the small bronchioles narrow, causing bronchoconstriction. We get mucus overproduction, and then basically what happens is that those small airway passages, those bronchioles, they start to close down, and they start to restrict airflow. It is restricted mainly in one direction. It can be both, but it is mainly in one. On inhalation, the expanding lungs exert outward pull, increasing the diameter of the airway and allowing airflow into the lungs. And then exhalation, the opposite occurs. So in exhalation, those airways decrease and they kind of trap the air into the lungs. Pulmonary edema, this is an abnormal accumulation of fluid in the alveoli, typically for patients who have CHF or some kind of heart failure. Pressure builds up in the pulmonary capillaries. That fluid then crosses the thin barrier and accumulates in the alveoli. That fluid occupies the lower airways, and it makes it difficult for the oxygen to reach the blood. Okay, so in CPAP, we're trying to push all that fluid out. Signs and symptoms include dyspnea, anxiety, pale and sweaty skin, tachycardia, hypertension, respirations that are rapid and labored, or a low O2 set. In severe cases, you may hear some gurgling. Even without auscultation, you may hear that they may be gurgling. It'll be like a deep kind of gurgling, rattling sound. It's not good. Okay. They may also cough up some type of frothy sputum. It's usually white. It can be pink, tinged with pink. In our treatment, we're going to assess and treat for any kind of inadequate breathing. So if we need to, we're going to ventilate them with a bag valve mask device. Holy crap. So you're just going to do that, okay? If you don't need to do that, then you can apply high flow O2, and then keep their legs in a dependent position if you can, so legs dangling. Typically what's going to happen is you're going to walk in on these patients and they're going to have some type of fan on them, and it's going to be on the highest setting, and it's just going to be blowing on them, because essentially what they're trying to do is create that CPAP. And then that CPAP may be used. Okay. Pneumonia. This is an infection in either one or both of the lungs. It can be caused by bacteria, a virus, or fungal. It's caused by inhaling microbes. And then those microbes, because the lungs are wet, moist, and dark, will start to grow and cause inflammation. So they're going to have shortness of breath, coughing, fever, and severe chills, chest pain. This chest pain is often more of a sharp pleuritic chest pain that hurts worse when they inhale. They can have a headache, they could be pale, sweaty, they could have fatigue and confusion as well. Treatment care is mostly supportive. We're going to assess and treat any kind of inadequate breathing. We're going to administer any kind of supplement or O2. You can apply CPAP to these patients as well. And in some cases, it's severe enough that it could cause inadequate breathing. Pneumonia typically leads to sepsis, especially in the older and really young infants type. Spontaneous pneumothoraxes, this is when the lung collapses without any kind of injury or obvious cause. Tall, thin people are at risk for these, as well as patients with COPD. Sharp pleuritic chest pain, shortness of breath, easily tired, low O2 sat, cyanosis, tachycardia, fast breathing, decreased or absent lung sounds, and then worsening. They'll get JVD and hypotension. ALS immediately if a pneumo is suspected or the patient has any kind of significant respiratory distress. Administer O2. CPAP is contraindicated in these patients because their lung is collapsed. There's nothing to inflate. So we're just going to do some transport to definitive care. Pulmonary embolisms, this is a blockage in the blood supply to the lungs. It's commonly caused by some type of deep vein thrombosis from like surgeries, cancer, or just kind of sitting passengers, airplane passengers, any kind of patient or any kind of person that has traveled for a long period of time, and they've been just sitting in one spot, then they're more likely to develop that DVT. It is a sharp pleuritic chest pain. It typically comes on all of a sudden, and they could have some shortness of breath, anxiety. They'll have some coughing as well, tachycardia, tachypnea. They may be lightheaded and dizzy, and they may have pain or swelling in one or both of the legs. These are difficult to differentiate in the field. We're going to administer O2 and treat for comfort, basically. And transport is what they need. Epiglottitis, this is an infection causing swelling around and above the epiglottis. In severe cases, that swelling can cause airway obstruction. They'll have a sore throat, painful swallowing, tripod position. They may have a sick appearance, muffled voice, fever, drooling, stridor. Typically, this is going to affect kids more than it is adults. Calm and comfortable. Do not inspect the throat. We don't want to irritate it. High flow O2 without alarming the patient, and then transport. Croup, again, one of these kid diseases. Typically, it's caused by a group of viral illnesses that causes inflammation to the larynx, trachea, and bronchi. The tissues in the airway start to become swollen, and then they restrict that passage They're going to have a loud barking cough. It's almost going to sound like a seal barking. They may have a hoarse voice. They may have some type of associated difficulty breathing that will typically resolve when the child moves to an upright position. They may have inadequate breathing, such as hypoxia, cyanosis, altered mental status, and then they may also have signs of significant breathing difficulty where they have some stridor going on. Treatment, so artificial ventilations if needed, transport immediately, call ALS, supplemental O2 if they need it, and then position of comfort. Bronchiolitis, so this is when the small airways become inflamed because of some type of viral infection, typically RSV. This is another one of those kid things. It's commonly associated with other cold-like symptoms such as runny nose, fever, and general illness. They can progress over a few days and worsen to include that respiratory distress. It's common for multiple children in the house to become sick because of this, and can cause respiratory distress and then progress to inadequate breathing. Treatment, so positive pressure ventilation, artificial ventilation if we need to, supplemental O2, either nasal cannula or non-breather. On kids, typically you're going to have to do some type of blow-by though, because they may not want anything on their face. Bulb syringes to suction the nose, and then clear the nose if the infant, if you need to. Cystic fibrosis, this is a genetic disease that typically appears in childhood. It causes this thick, white, sticky mucus to accumulate inside the lungs and the digestive system, and it can cause difficulty breathing and nausea, vomiting, that type of thing. It usually is a life-threatening thing. These kids, because it is genetic, they know about it at an early age, and these people typically do not live long. They typically live to be in their 30s or 20s. So they're going to have coughing with large amounts of mucus, fatigue, frequent occurrences of pneumonia. They'll have multiple hospital stays. They may be coughing up blood. They may have also nausea, vomiting, and weight loss. Treatment. So the caregiver, mom, dad, whoever it is going to be your best source of information for these kids, and to get a baseline. And they can often guide that treatment. They'll have typically these patients will have a binder or some type of piece of paper that says their treatment guides. Viral respiratory infections. So it's an infection of the respiratory tract. It's common in adults, and it includes like the flu, COVID, pneumonia, all those things. Okay. It often starts as a scratchy throat with sneezing, runny nose, and fatigue. They can get fever and chills. The infection can spread into the lungs and cause shortness of breath. That cough may be persistent, and it may produce a yellow or greenish sputum. If it does, that typically means that it is a viral infection. Typically, it's going to be supportive treatment and treat symptoms. So supplemental oxygen, bronchodilators, so give some albuterol. And if the infection is viral, it cannot be helped by antibiotics. Antibiotics are not going to do any good. But good hygiene can prevent these viral respiratory infections. So let's talk about the metered dose inhalers. These are prescribed. It provides exactly measured dose of medication, and it's most commonly prescribed for conditions causing bronchoconstriction. So before we administer the inhaler, we're going to make sure that we have our 5 rights. So right patient, right time, right medication, right route, and right dose. We're going to check the expiration date to make sure it's in date. We're going to make sure that it's the patient's own medication, and that our patient is alert enough to use the inhaler. So when we administer the inhaler, you're going to have the patient exhale deeply, have the patient put their lips around the opening, press the inhaler to activate the spray as the patient inhales. Make sure that your patient holds their breath as long as possible so that the medication can be absorbed. If they have a spacer, you can depress the medication and allow it to go into that spacer, and the patient doesn't have to like breathe simultaneously as you spray it in. So small volume nebulizers, this is the same kind of medications that are used in the meter dose inhalers. They just kind of last a little bit longer, and it's run through oxygen. It produces a continuous flow of that aerosolized medication that can be taken in during multiple breaths, or over several minutes. And it gives the patient a greater exposure to the medication. So this is a common setup for a nebulizer, small volume nebulizer, and you guys can give the albuterol without it having to be the patient's own through this nebulized treatment. Of course, if you guys have any questions, let me know, and we will answer those questions as I can.